Good evening, everyone. Thank you for joining us. My name is Kylie Hall. I am the project coordinator in the NDSU Center for Immunization Research and Education. And on behalf of our center, I want to thank you all for joining us tonight to learn more about COVID-19 vaccines. Before we begin, I do want to make sure I introduce both of our panelists. Our first presenter tonight will be Dr. Paul Carson. Dr. Carson is an adult infectious disease physician from Fargo. He is board certified in internal medicine and infectious disease. He was a physician at Sanford Health, which was previously Merit Care for over 25 years, and he's currently a professor of practice in the NDSU Department of Public Health. He is also the medical director for the NDSU Center for Immunization Research and Education. Dr. Tracy Newman is our second presenter. Dr. Newman is a board certified pediatrician and she practices in Fargo as well. She has a master's degree in public health and has been in practice for 11 years, and 9 of them have been at Sanford Health. Dr. Newman is a member of the Fargo School Board and also serves on the Fargo Cass Public Health Board of Health. We will have time at the end of the presentations for Drs. Carson and Newman to answer questions. So if you have questions, please type them in the Q&A box found at the bottom toolbar. This session is being recorded and it'll be available on the NDSU CIRI website and also the North Dakota Department of Health website in the near future. Dr. Carson, you can begin.
Great. Well, thank you for the introduction, Kylie, and welcome everyone. Very glad to be able to visit with you this evening. I'm going to share my screen and we'll go through a bit of formal slides and a bit of a formal presentation because we've heard many of the questions that are typically posed out there, and we'll walk through what we hear most often. And then we'll give opportunities for listeners to ask their questions. And this evening is really meant, especially for those folks that are still undecided about whether to take the COVID-19 vaccine or not. I know there's probably a mixture of people who are on here that have been vaccinated or considering it or maybe even very opposed. But we'd like to try our best to answer any of your questions and concerns. So we'll go through, as I said, some of the most common questions on the vaccine. And then Dr. Newman will particularly focus after I go over some of the more general ones. She'll focus on the pediatric questions and the pediatric issues. So first, before kind of getting right into those questions, let's just briefly go over who's vaccinated. Where are we at? As of just this last week, we have about 80% of people over the age of 65 having received at least 1 dose of the vaccine. So that's very good news because we know that the elderly, in fact, age is the greatest predictor of having a bad outcome from a COVID infection, and having over 80% of our people over the age of 65 vaccinated is very good news. That still means 20% of people who are at the highest risk aren't vaccinated, and we'd really like to see that number up well into the 90s if at all possible. Other groups, if we look at teachers in North Dakota, 67% of all North Dakota teachers have had at least 1 dose of the vaccine. And we have 21 school districts where over 70% of the teachers have been vaccinated. So that's good news. That's been, that was a concern of a lot of teachers for being able to get back into the classroom setting and teach. And we're all anxious for that to be back to normal now. Another group to kind of look at is healthcare providers. I was able to get some data from our regional Sanford Health System and Essentia Health System. I don't have it for all of the healthcare systems in the state, but for these 2 large systems, we know that about 80% of all the healthcare professionals are now vaccinated. And if you drill down a bit further on that, it's about 90% of all doctors are vaccinated. And one of the things that we kind of hope to come from this session with you all is that if polling data can be believed, the polls suggest that when people are seeking information about medical decision-making and medical information, the person that they uniformly say they trust the most is their doctor. Close after that is their pharmacist. So and that's another highly vaccinated group of people. So we'd love for you to be having conversations with your doctor and with your pharmacist about why they wanted to get to the front of the line when they had the opportunity to get the vaccine, and help advise you on your decision-making. If we look at the broader country, the percent of the adult population with at least one dose of the COVID-19 vaccine is about 58%. And if we look at it, so that's nationally, that's adults, so people over the age of 18 that have had at least one dose, it's about 58%. And in North Dakota, we're at about 52%, so a little bit behind the rest of the country. But I think it's probably worth noting that in North Dakota, we've kind of plateaued. The amount of vaccine that's rolling out now is much, much less than over the last couple of months. And now we're kind of in a phase where we're, trying to address the questions that people have that are a bit more concerned or a bit more hesitant about receiving the vaccine. And so kind of getting into some of those concerns and what some of those questions that have kind of kept people on the sidelines, understandably, I think there was a lot of unknowns as we've kind of gone through things. But I do want to let you know that we actually know a lot more now. Even it's almost every day we get new data, new studies, new research that's really expanding our knowledge base rapidly. So let's go through some of the most common questions. I think probably number one is that this kind of question that COVID-19 vaccines were developed too quickly and the whole process was rushed. How can we know that these are safe? And I think that's a fair question. So, we have this sort of new vaccine technology, or what appears to be new vaccine technology, these messenger RNA vaccines sort of coming, what seemingly coming out of nowhere. And how can we be confident that these are something safe? Well, I think a lot of credit actually goes to the Trump administration, who put into place Operation Warp Speed. Now, maybe that name wasn't the best name because it sounds like things were rushed, but what Operation Warp Speed did was it was a partnership between the Trump administration and some collaboration with the FDA on how can we find a way to safely yet expeditiously bring candidate vaccines to the people who need them. Well, let me go through that a little bit. So if you look at the typical timeline for developing a new vaccine, it's actually pretty long. At the beginning, you have the concept that's kind of tested out in laboratory experiments. Can we find a candidate vaccine? Can we produce it in a steady way? Is it stable? And then if that all looks good, you move it into animal studies and you see if you can protect animals with the vaccine. You see if it's safe in the animals. You do different dosing studies, et cetera. And if all that looks good, and that can take years, sometimes up to 10 years, if that all looks good, then a pharmaceutical company can file what's called an investigation of new drug to the FDA saying, we want to try this in humans. And if that all looks good, the FDA says, yes, you can start trials in humans. And these are the pivotal studies that we have established through the FDA to assure safety and efficacy. Phase 1, phase 2, and phase 3. Phase 1 studies are in small groups of people, typically dozens of subjects, where you give the vaccine candidate and you test to see if they mount a good immune response, and you look for any overt bad safety problems. If that all looks good, you move to phase 2, where you typically vaccinate hundreds of people. And here we're typically doing dose finding. What's the lowest dose of the vaccine we can give to still get a good immune response? And again, are there any safety signals? And again, how good is the immune response? And if that all looks good, then it moves to the most important part, which is phase 3 studies. Phase 3 are where you vaccinate typically thousands to tens of thousands of people and compare them to an unvaccinated group or whatever the standard of care is at the time. And you look to see, does the vaccine actually protect that population from the disease that you're studying? And you have a lot more people to ask the question about rare safety problems or adverse events. If that all looks good, then the company submits what's called a biologic license application to the FDA. And then the FDA will typically review that for 6 to 12 months. And once they approve it, then the pharmaceutical company starts to manufacture. So that's a long process. So how did we get there, and how does it compare with the COVID vaccine? Well, a lot of people don't understand is that actually that long preclinical exploratory animal science stuff had for the most part been done. We've actually been studying, not me personally, but researchers, a very prominent one at the University of Pennsylvania had been studying mRNA, messenger RNA vaccines since the mid-90s, and had been working out the process to develop these and see if they could make them safe and effective. And then when the original SARS virus came along in 2002, SARS-CoV-1, which killed almost 900 people, had a 12% mortality rate, was very scary, not nearly as contagious as SARS-CoV-2, but much more lethal. Lots of researchers said we need to be looking at vaccines for these serious coronaviruses. Another one that came along in 2012 was MERS, or Middle East Respiratory Syndrome. These are closely related to SARS-CoV-2, and several candidate vaccines had been tried and moved through pipelines. They never went any further because the original SARS disappeared, and MERS, or Middle East Respiratory Syndrome, doesn't affect very many people. It's pretty limited to the Arabian Peninsula. So those never went into any further clinical trials, but all this exploratory preclinical and animal data had been worked out with vaccines and vaccine candidates that were very, very similar to what was looked at for SARS-CoV-2. So that cut out a lot of time and gave a jump start to be ready fairly quickly for a few other animal studies and then the clinical trials in humans. And the exact same phase 1, phase 2, phase 3 studies were insisted upon by the FDA for any candidate vaccines that would be used for SARS-CoV-2. However, there are a couple of differences. What the FDA did say, in the interest of trying to get something out in a crisis pandemic, was that instead of waiting till the very end and reviewing this for the typical 6 to 12 months, they would do a rolling review as the phases marched along. They would look at each phase as it rolled out. And then what they also allowed was that if things were looking good towards the end of phase 1, they said you could start phase 2 a little bit early. They still had to complete all of phase 1, but they could sort of overlap these, and phase 2 could overlap, or phase 3 could overlap phase 2 a little bit if phase 2 was looking good. All phases had to be completed, and that most important phase, phase 3 in particular, had to be completed. And then the Trump administration's Operation Warp Speed gambled with taxpayer money, saying, we'll take the burden off of the pharmaceutical companies to manufacture these now while we are conducting the clinical trials, in the hopes that one of these would work out so that they were ready to be distributed right away should they prove to be safe and effective in the phase 1, 2, and 3 studies. That was a gamble, and it was a gamble that paid off, so that we had these ready to go for the most part after the clinical trials were completed. So the differences between traditional vaccine trials and the COVID vaccine trials are, one, we had very rapid enrollment. So one of the things that can slow you down is people, trying to get people to participate in these trials. Lots of people were interested in participating in these trials. They had no problem recruiting and enrolling. Then, as I said, the FDA allowed some overlap between phase 1, 2, and 3. Then the government started manufacturing before approval so that it would be ready to go. And then the last thing I think we do need to acknowledge is that the FDA said that they would allow a somewhat shortened window of follow-up. So the typical follow-up that's recommended for most vaccine trials after a subject is vaccinated is 6 months. They said they would allow it to be shortened to 2 months. Now, is that okay? So does that make sense? Why was that? So the reason they allowed for that 2-month follow-up is that we know from virtually all past vaccine trials that over 90% of the serious adverse events will occur within the first 6 weeks after vaccination. So giving 8 weeks, we know, at least if patterns hold out like they've held with every other vaccine, we would find the vast majority of the serious adverse events in that time span, which makes sense. If you think about the immune response, it's by far greatest in the first several weeks to a couple months after vaccination. And if the immune response is the thing that protects us, and maybe the thing that has some collateral problems or damage, it's usually going to be highest in that early period, not as the immune response fades away later in time. Now, we can actually put that question or concern to rest, because now at least the Pfizer vaccine has the full 6 months safety and efficacy data. They've completed it. They kept those people enrolled. They kept following them. And now they have already filed for full FDA approval, just like you would do with any normal vaccine, with their 6-month safety and efficacy data. And Moderna is close on its heels. They are anticipated to do the same very shortly. Another question or concern that we have, I would say, is this idea that 99.4% or whatever you say, 99.4% of people with COVID survive. I'm young, I'm healthy, I'll take my chances with the virus. Well, that is true to some extent, but it's an unnuanced truth. And we need to drill down on that a bit further to understand why that isn't an adequate enough reason to skip the vaccine. So first of all, if we take death, death is not equal by any means, even from decade to decade of age. So if you take the 18 to 29-year-old group, so typically 20-year-olds, as sort of your baseline, it is true that their mortality rate is extremely low, but it goes up very rapidly for each decade of life you go beyond that, almost exponentially, 4 times higher in 30-year-olds, 10 times higher in 40-year-olds, 30 times higher in 50-year-olds, and so on, to where you're getting out to 70 and 80-year-olds. You're 220 to 630 times more likely to die than a 20-year-old. So look at your own age and look at where you fall in that, and understand that your risk isn't the same as someone very young and healthy. But then the other thing that we need to kind of point out is that, what does survival look like? I mean, it's not just survival that we want to kind of address and protect. It's illness and disability and chronic health issues. If you look at hospitalization, which happens a lot more often than death, anywhere from 2 to 15% of people who get sick with COVID will land in the hospital. And there again, if you're in your 30s or 40s or 50s or 60s, your risk of hospitalization goes up significantly as you get older. Add on to that, risk of death and risk of hospitalization go up markedly if you have an underlying morbidity or underlying health problem. Obesity is the #1 risk factor aside from age. 1/3 of the population is obese. If you look at other chronic medical conditions like diabetes or chronic lung disease or chronic heart disease or chronic kidney disease, up to 47% of the population has one or more risk factors for a bad outcome from COVID. That's a whole lot of us. And then we are now learning much more about long COVID. Every day there's a new study being published on this, just a plethora of research on the long-term outcomes from COVID. And it's not a good picture. We are finding large percentages of people that have symptoms lasting weeks to months. These are things like brain fog, so difficulty concentrating, difficulty attending to tasks, fatigue, probably the most common symptom, headache, dizziness, insomnia. A recent study that was just published found new diagnosis of an anxiety disorder and a new onset or new diagnosis of depression were much more common in people who had had a diagnosis of COVID compared to their age and other matched non-COVID infected cohorts. Lung scarring and heart inflammation has been described. Recent study in the Annals of Internal Medicine found a much higher incidence of new onset of diabetes mellitus shortly after COVID. I had several of my colleagues at Stanford tell me that they were observing this a little bit before this study, and then this study came out. We've all heard and seen, people who say they've lost their sense of taste or smell, and a handful of those people are having those problems go on for months. I know of a few people personally that are 8 months out without any sense of taste or smell still coming back. A recent study in one of the endocrinology journals just identified that men who had COVID, even outpatient COVID, had a much higher incidence, almost 6-fold higher compared to their age and health matched counterparts of erectile dysfunction. And this makes some sense because COVID has a real propensity to affect vascular tissue, which is what underlies erectile dysfunction. So that, and the average age in that study was 39 years old. So the long-term issues of COVID are very significant. We have now clinics being established to address just all the different problems from long COVID. And then the other thing that people may not appreciate is that these are coronaviruses that are pretty contagious. They are very similar to the seasonal coronaviruses that cause the common cold. And virtually all of us have been infected with seasonal coronaviruses by the time we're 4 years old, and then we get infected with them intermittently, over cold and flu season, over the years. So think about how many colds you've had over the years. This behaves just like that. It's very probable that if we're not vaccinated, and we haven't had it already, that we will get it at some point in the next 6 to 12 to 18 to 24 months. I think it's not an unrealistic expectation that the majority of people that have not had it will get it or will be exposed in one form or another in the next couple of years, unless we hit herd immunity, which is a whole nother issue and a whole nother question. Another thing that we sometimes hear is that this was actually on a newscast recently. Over 3,000 people have died from the COVID vaccine. Is this true? No, this is not true. You can say that 3,000 people have been reported to our safety systems, what's called the VAERS database, after a COVID vaccine. There's a big difference between, from a COVID vaccine and after a COVID vaccine. And I think if I asked most of you to think about that for a few seconds, you'd be able to come up with why that's so different. But let me help with that. If you take a look at 10 million Americans and follow them over 2 months after you give them something completely benign, like a sugar pill, and watch them for 2 months, which is what, shine a spotlight on them and see what happens to 10 million typical Americans. About 4,000 of them will have a heart attack. About 1,700 of them will have a blood clot of some form or another. Almost 4,000 will have a stroke. Almost 10,000 will be diagnosed with a new diagnosis of cancer, and almost 14,000 will die. Now, we are vaccinating about 10 million people a week, actually a little more than that. So if we gave them a completely safe vaccine, something that was 100% safe, and followed them over the next couple of months, there would be we should expect 4,000 heart attacks, 1,700 blood clots, 4,000 strokes, 10,000 cases of cancer, 14,000 deaths. So it's vitally important to try and drill down, like, was it just the background of what happens to people, because people get sick and people die and people have bad things happen to them, or was it from the vaccine? And if you think about who got vaccinated at first, it was often the frail, sick, elderly people in nursing homes. I mean, in the nursing home where I'm a medical director, we had several people in hospice that were vaccinated. Of course, a number of them died over the next 1 to 2 months. So the only way to kind of get at this, like, is this really a problem from the vaccine, is you have to have a control group. You have to compare it to a similar group of people that are unvaccinated. And of course, that's what's done in the clinical trials. That's usually in the tens of thousands. But to be fair, if you're looking for problems that may happen in maybe out of 1 out of 100,000 or 1 out of a million, you need to look at a lot more people. And those become unfeasible in a clinical trial, which are very expensive and very hard to do. But we have other monitoring systems that do just this on an ongoing rolling basis as vaccine rolls out. One of the most powerful ones is something called the Vaccine Safety Data Link system. And if people have an interest, I can get more into that. But we have, on a rolling basis, weekly checks in a big system of healthcare systems with 12 million people enrolled in their electronic medical records, where we have vaccinated people compared to unvaccinated people for a plethora of different problems to see if there's any signal popping up. And so far, there isn't. The only thing popping up is some of the side effects that we know about and you've already heard about. And so let me talk about those. So one of the other common reasons for people to be cautious about the vaccine is that they just don't know that they want to deal with the known side effects. Well, if we take a look at the side effects, it is true that a fair number of people will get a sore arm or tenderness in the injection site. That happens in maybe 25 to 50% of people after the first dose, and a little higher, maybe 50 to 75% of people after the second dose. More concerning to people, I think, is like the systemic side effects, the fatigue, the fever, the chills, the muscle aches, the headache. And those were reported in 25 to maybe 50% of people in the clinical trials. Actually, as it turns out, though, in the real world monitoring this, a big study published out of the UK where they followed hundreds of thousands of people, they actually found those systemic side effects were a lot less common than in the originally reported trials. in the neighborhood of like 5 to 10% with the first and second dose. So in the real world, kind of rolling out of the vaccines, those systemic side effects, actually, most people don't get. And if you do get them, I had some headache after my dose of the vaccine. It lasted about a day. And that's true for most people. These are self-limited. I should say, though, that there are some serious adverse events that can happen. Anaphylaxis or severe allergic reaction can happen in anywhere from 2 to up to 11 people per million doses of the vaccine. Those have been fairly manageable with proper treatment and medication for severe allergic reactions. And vaccine centers and people giving the vaccines carry those treatments to manage that. And then we should mention also the Johnson & Johnson vaccine was found to have this unusual type of clotting disorder that caused a very serious form of a blood clot in one of the main veins in the central nervous system. And that is in the order of 2 to, I think it's up to about 2 to 15 per million, depending on the age and sex. And so it's really in a problem mostly in reproductive aged women. And we can get more into that if people have more questions on that. Other question that comes up is, I've had COVID, maybe I don't need the vaccine. Well, certainly getting the vaccine is safer than getting COVID, but let's say you've already had COVID. We actually have now a number of studies that show people who get the vaccine compared to people who had natural infection make much higher antibody levels, on the order of about 10-fold higher. And a recent study that was just published in the New England Journal of Medicine showed that the antibodies made from the vaccine do a better job of neutralizing some of the variants that are circulating, like the South Africa variant and the UK variant and the Brazil variant. They do a better job of neutralizing those viruses than do antibodies from natural infection to the original virus. So the vaccine does a better job. And now we've also got new data that shows the vaccine also decreases asymptomatic COVID infection and decreases transmission. This was unknown at the beginning. One of the concerns raised, we've actually got a bunch of data coming in now showing this, which we kind of thought was going to be the case, but a lot of studies from different countries all validating this. So we now have over 245 million doses of the vaccine that's been given in the US under one of the most intense safety monitoring systems in our history of looking at these. And I think the overwhelming evidence is that these vaccines are looking to be safe and effective. And I think for most of us believe that really our only major path back to normalcy, visiting our grandparents without worrying that we're bringing something dangerous to them, attending our religious services, going to concerts and sporting events, having big dinner parties with our friends, kids back in school doing what their teachers doing, all the things that, we like them to do, that our best path back to that is through vaccination, and really our only realistic path back to that. So I'm going to stop there, and you can start posing some of your questions in the Q&A box if you want. Don't pose questions about pediatric issues or child issues, because Dr. Newman's going to now talk and address those. And so you may have your questions answered about those. But I think you could go ahead and, if it's on the more general issues about the vaccine or things that I touched on that you want more clarification on, you can start to put those. We may answer some of them right in the Q&A box and people can see those, and we may elevate some of those into a oral discussion on those. So I'll stop there and turn it over to my friend and colleague, Dr. Tracy Newman.
Thank you, Dr. Carson. See if I can get this to work here. Are you guys seeing that okay?
Yes.
Okay. Well, thank you again, and thank you, Kylie, for that introduction. As you all heard, my name is Tracy Newman. I am a pediatrician here in Fargo, and I'm here tonight to talk a little bit about COVID-19 and kids, what we know, what we're learning, and what vaccines might look like for them. So I wanted to start by just recapping our total burden of disease in the United States, looking at our total case counts. We know to date in the United States, we've had more than 32 million COVID-19 cases, and unfortunately, we've seen greater than 572,000 deaths. Obtaining pediatric data is a little more involved. Age distribution for cases is reported on health department websites of 49 different states, as well as Puerto Rico and Guam. And then we get it from larger entities like New York City and Washington, D.C. So from that data, we can estimate that there's been around 3.85 million COVID cases in kids. And again, unfortunately, more than 300 deaths. So children have represented around 14% of our accumulated cases. And for just this past week, ending in May 6th, they accounted for 24% of our new weekly reported cases. And we've been really seeing that number kind of trend up and increase of late. It's hard to say if that's due to more adults receiving the vaccine or other factors. And one other point while we're on this slide, of the 303 cases of deaths that we know, the CDC has reported 127 of those are in the 12 to 17 age range, which is now the age we can vaccinate for. And that would account for 1.3% of all deaths among adolescents. So looking a little more at our North Dakota data, this is cases by month, again, in that 12 to 17-year-old age range. We know that 13% of North Dakota children in this age have tested positive to date for COVID. Of course, you can appreciate we had our peak back in the fall. Our highest cases were between October and November. We were well above 2,000 cases. We recently had another little increase of about 13% between the March and April timeframe. And the vast majority of these cases, 77% or more, were due to community spread or household spread for kids this age. In the US as a whole, we've seen similar time frame for this age group, more than 1.5 million cases. And the peak for the US as a whole was a little bit later, more of the December, January time frame. So a smaller subset of states, not all states, report for age distribution on mortality and hospitalization rates for kids. So from that available data, it is fairly safe to say that severe COVID-19 illness and death is uncommon in children. However, COVID-19 is a new disease, and as this virus spreads, we know that some pediatric patients get simple common cold symptoms or no symptoms, and other children unfortunately get very sick and need to come into the hospital to be cared for. North Dakota has reported 20 hospitalizations just for that 12 to 17-year-old age range. So at this time, again, it does seem that severe illness is unusual in children, but I always say, you know, the risk is not zero. We have seen COVID-19 illnesses and deaths be reported in children under the age of 1 and those with underlying health conditions, particularly things Dr. Carson said for adults too: obesity, asthma, diabetes, and particularly if children have more than one underlying health condition, they are at much greater risk. So we know that COVID-19 has hospitalized at least 15,000 children, and that would really be on par with a similar influenza hospitalization rates for a typical flu year. But during that same time period, we have seen COVID-19 be responsible for more than 300 deaths in children, and that would be more than double the typical rate for influenza. So just to make the point here that as pediatricians, we typically recommend seasonal flu vaccines for kids, and they're fairly readily accepted, at least in my practice. So I'm very hopeful that the COVID-19 vaccine will be as well. I wanted to briefly touch on a rare but serious condition associated with COVID-19, an entity called Multisystem Inflammatory Syndrome in children, or MISC. This is an illness that presents with fever, inflammation throughout the body, and problems with at least 2 organ systems. Things like the heart, lungs, brain, and blood vessels, and many more have been reported. It is a severe illness that requires hospitalization for children. In fact, 60 to 70% of patients require being admitted to intensive care, and 1 to 2% of these patients have died. We know that 99% of these cases test positive for SARS-CoV-2, the virus which causes COVID-19, and the remaining 1% have exposure to someone with COVID-19. So since mid-May of last year in 2020, the CDC has been tracking reports of MIS-C and really working to determine why some children seem to develop this after COVID-19 and others do not. To date, we have had 8 cases of MIS-C in North Dakota. For the US as a whole, as of October 2020, we had greater than 1,000 cases. From February, we surpassed 2,000 cases, and now we have exceeded 3,000 cases as of last month. Our total case count is 3,185, and we have seen 36 deaths. There are multiple cases under continued investigation. The CDC thoroughly reviews every case reported of this. You have to meet fairly strict criteria to be labeled with this. So there does exist an urgent need for us to collect more data on the longer impacts of this pandemic on children, of course, to their physical health, but also to their social and emotional health. We are having more and more information come out about long haul syndrome, as Dr. Carson referenced. That's true in kids too, I'll touch on that. And really, we've seen increased rates of obesity, social isolation, academic loss, food insecurity, and just really a lack of access to the safety mechanisms that are offered by our schools. From the mental health perspective, we know that children respond to stress differently depending on their age or stage of development, but across the board, we have had high rates of anxiety, depression, and post-traumatic symptoms reported. So Dr. Carson approached this a little bit with adults, but yes, there is rapidly emerging evidence about children being at risk for persisting symptoms following COVID-19 infection. This is also known as long COVID. Very recent preprint research from Italy is suggesting that children can have this entity regardless if they had symptomatic disease or not. And children are having at least one persistent symptom weeks after being diagnosed. In this study, 43% of those children reported feeling impaired during everyday activities. Other research out of the UK and Italy has shown that symptoms lasted an average of 8 months, and they tend to mirror physically the adult symptoms, things that we heard earlier like weakness, fatigue, headache, abdominal pain. But parents also reported sort of those mental effects in children as well. They reported their children had trouble concentrating, remembering information, doing everyday tasks, and issues with short-term memory. So hopefully we'll have more to come on that. So while children do tend to fare better from acute COVID-19 infections, and they are infected at lower rates, they still can be the source and recipient of outbreaks. And certainly with our new variants, we know they're more contagious and having a worse effect on our young people. Also, most children have a grandparent, teacher, or other person in their lives who might be susceptible to a worse outcome from COVID. Wanted to briefly touch on adolescents and their ability to spread this virus. There's been a lot of literature around this. Some studies have found, similar infection rates in children and adolescents versus adults, while other literature suggests lower rates in children. Adolescents may be more likely to be infected than younger children, especially children under the age of 10. And that data comes from contact tracing information, test positivity rates, and population level prevalence data. But secondary transmission from adolescents can and does occur. While transmission among students is fairly unusual, several studies have suggested transmission is more likely to occur in a high school setting than an elementary school setting. And outbreak investigations have demonstrated efficient transmission among children and adolescents, including to older household members. So teenagers are social. They congregate in confined spaces such as classrooms and buses and lunchrooms. They also participate in a multitude of extracurricular activities, which is great. And as I mentioned earlier, we've certainly seen the harm done to children's mental health as they've missed out on experiences during the pandemic. And the hope is that higher vaccine rates can ensure that these activities can continue safely. Youth sports have seemed to be a particular magnet for outbreaks. So a safe way to ensure that our children can continue participating in the sports they enjoy and avoid disruptions to their practices and game schedules is to have them vaccinated. Fully vaccinated adolescents who don't have any symptoms will no longer need to quarantine or even test following an exposure to COVID-19 because we know their risk of infection is low. And furthermore, children under the age of 18, they make up around 24% of the US population. So it's important that we prioritize societally, vaccinating them if we want to help improve our overall herd immunity. So as was referenced earlier, our only hope of ending this pandemic is having safe and effective vaccinations. This is especially true for educators and students to return to normalcy for schools. We know that immunizing our educators and our parents and students can help us return to traditional school schedules, all the extracurriculars, all the athletics, not to mention, domestic and international travel. So the FDA has granted emergency use authorization to Pfizer, Mrna, and Johnson & Johnson COVID-19 vaccines. As of very recently on May 7th, Pfizer sought full FDA licensure and is likely to obtain that by this summer. And as Dr. Carson told us, the Mrna is close behind and that they're expected to apply soon as well. For kids, Pfizer's 2-dose mRNA vaccine is currently the only vaccine that's available for children now 12 and up. It has been being safely administered to kids 16 and older. And just very recently, of 3 days ago, the FDA authorized emergency use for Pfizer vaccine for children in the age range of 12 to 15. And as of yesterday, the CDC Advisory Committee on Immunization Practices voted unanimously 14-0 to approve the vaccines for this age range. There are ongoing trials from the other two manufacturers in this range, and Mrna has reported actually 96% efficacy for children in their trials ages 12 to 17. And I just wanted to note that both Mrna and Pfizer are conducting trials for children significantly younger, all the way down to age 6 months. And I think we can expect to see trial result data later this fall with potential vaccine availability early 2022. This is a timeline just examining Pfizer's predictions. The first two I just addressed, but just to make the note that they have come out publicly saying they expect completed trial results in the ages of 2 to 11 by as early as September, and they will plan to seek emergency use at that time. And then for the younger ones, ages 6 months to 2, hopefully by November. And their hope is to have all ages either in emergency use or fully approved by December of this year. I wanted to thank you, Dr. Carson, for going through all how vaccines work and the trials that we go through. I thought I might just do a few highlights from Pfizer's phase 3 adolescent trial. That's the one you've probably seen in the media this week. It's been talked about a lot. It was just made public this week. This was a smaller trial than we're used to for vaccines. And as you stated, it was a shorter time period than we're used to, but as to be expected during a pandemic. So this trial contained 2,260 adolescents, about half of which received the COVID vaccine. And there were 18 COVID-19 cases reported in the placebo group and none in the vaccinated group. So this is how you're hearing that 100% efficacy rate. That's where that's coming from. And that is for symptomatic lab confirmed illness. Also of note, there was no significant safety concerns from this trial. There was no hospitalizations or MIS-C from the trial participants. And the side effects that were reported by the kids were very similar to the ones stated earlier for people 16 and older. So another unfortunate fallout we've seen from this pandemic is a delay in routine well childcare and other childhood immunizations. And this puts us at risk for outbreak from other vaccine preventable illnesses. So again, as of yesterday with this release, the American Academy of Pediatrics really urged all eligible children, teens, and family members to be vaccinated as soon as possible for COVID-19. The AAP now supports giving other childhood immunizations at the same time as COVID-19, so we no longer have to give these separately, and that will be particularly important for children who are already behind on their regular vaccines. I did have a few slides in here about pregnancy and breastfeeding. I think I might skip over those. Those are questions I get asked frequently. But if there are questions, we could come back to that data just for the time's sake. So I'll just end by saying that COVID-19 vaccines are available for every North Dakota now for the age over 12. They're available at a multitude of places listed here: local public health, your hospitals and clinics, and local pharmacies. If you're having trouble finding a vaccine, you can check with the North Dakota Department of Health or visit vaccinefinder.org to find availability. With that, I'll turn it back over to you, Dr. Carson.
Right. Kylie, you've been kind of monitoring the question box. Do you want to?
Yeah, absolutely. So the first question I have, maybe we'll start with you, Dr. Carson, is an attendee who is saying that they had Guillain-Barre Syndrome in 2020, so just last year. They say they're currently fine, but they still have numbness in their feet. They're nervous to get the COVID-19 vaccine, and they're just wondering if you could suggest how safe it will be for somebody who's had Guillain-Barre.
Right. So just for people who may not be familiar with this, Guillain-Barre syndrome is an autoimmune condition where your immune system attacks your peripheral nerves, and it can lead to kind of an ascending paralysis that can, most people survive that okay, but it can be pretty debilitating and pretty scary. We see that there was some very rare cases of Guillain-Barre syndrome after certain influenza vaccines. This has not come up with any of the COVID vaccines. It is one of the conditions that's actively monitored for a problem in what I tangentially referred to the vaccine safety data link system. So they are looking at vaccinated people versus unvaccinated people for the incidence of Guillain-Barre syndrome, and nothing is coming up there so far. But I can't answer that directly. We just haven't seen anything there. And I'm sure there's not enough people like yourself who had a history of Guillain-Barre syndrome to say, is it a problem or not? I can say that with influenza as an example, where there's this very tiny increased risk of Guillain-Barre syndrome. It adds about a 1 out of a million increased risk. The risk of actually influenza itself causing Guillain-Barre is significantly higher than the vaccine itself. And I would be concerned about the same thing with, COVID virus. I would be as or maybe more worried about your risk of a flare of Guillain-Barre syndrome from a COVID infection than from the vaccine. So, that's about as best as I can tell you with that.
Maybe you can answer the next question, Dr. Newman. Someone is wondering if you can take Tylenol or similarly maybe ibuprofen after getting your COVID-19 vaccine.
Sure. I'll kind of answer this the way we answer this for all vaccines. This has changed over the years. Many years ago, you might remember we used to have parents actually pre-dose with kids with Tylenol before vaccinations. Then there was a period when I was in training where we would give it at the same time. And now most recent recommendations are actually to try and not give these types of medications. What I usually tell parents is, these medications are anti-inflammatory. They're going to kind of suppress the immune system a little bit or suppress the reaction. And we want the body to mount a response. We want the body to respond to this. So I usually say, if it's miserable, if your child is clearly showing you signs of discomfort, clearly if they have high fevers or other signs of distress, it is reasonable, yes, to give a dose of Tylenol and ibuprofen for comfort, but it's not something I would do preventatively. It's not something I would jump to. You want your body to respond.
Okay.
And if I can add from personal experience, I was pretty determined not to take any of these. And it's a theoretical thing that it might blunt the immune response. There's not great evidence on it, but I was pretty determined. And then I had a pretty good headache at about 24 hours after the first dose, and I just thought I'm gonna take some ibuprofen, and it went right away. It disappeared with some ibuprofen afterwards, and I buckled at about 24 hours. But I don't think people should feel terrible, like if they're really uncomfortable or really suffering from some of those side effects. They do work. Tylenol and ibuprofen do help substantially. If you can tough through it, I'd say tough through it. If not, don't feel bad if you ended up taking some.
I think that's a great point. I'll just add one more thing about pediatrics. We encourage other ways to soothe children as well. There's been a few studies out quite well done showing that if you breastfeed or nurse a child after vaccines, they actually release a similar sort of pain results and pleasure hormones as taking Tylenol. So you can try other things as well for kids.
Yeah, thanks, Dr. Newman. Okay, Dr. Carson, we have a question that's kind of two questions. So of the 3 approved vaccines, is one better than another? And to tag on to that, somebody is wondering, is the Johnson & Johnson vaccine safe?
Right. So these are good questions, and I'm glad you're asking. So I think between the Pfizer and the Moderna vaccine, I mean, they're literally almost the same thing. They're encased in slightly different fat bubble to protect them, but it's essentially the same messenger RNA molecule, and their data looks so similar you could almost kind of overlap them. So I really don't think there's any difference between the Moderna and the Pfizer vaccine. I'd take either of those quite readily. The Johnson & Johnson vaccine I'm going to share my screen again here. So the Johnson & Johnson vaccine did identify this condition called thrombosis with thrombocytopenia syndrome. So that's kind of a mouthful, but thrombosis means clot. Thrombocytopenia means low platelets, one of the little cells that make clots, and people getting clots with this syndrome. That's unusual. So that's not something we see very commonly. This was found in our safety monitoring system. So this is a testament to the safety monitoring systems we are using. And they did a very rapid drill down on this. And this is basically what they found, is that for females of reproductive age, so you can see the 18 to 29, 30 to 39, 40 to 49, 50 to 64, and over 65. This is the rate per million doses that was seen. And here's the rate in males. So, and this is pretty updated because initially it was just 15 cases now with further monitoring, and they've sent out all these alerts for doctors to be on high lookout for this. They've got about 28 cases, and you can see the biggest risk groups were kind of the 30 to 39, 40 to 49-year-old females with 12 to about 10 cases per million. So this is still very rare. In males, it's very, very rare, but it's not zero, and it's a serious condition. It's treatable, but this has led to a few of these people dying from this. My advice would be, in the U.S., we have ready access to most of these vaccines. If I was advising females of reproductive age, 18 to 50s, I would say choose the Pfizer or the Moderna vaccine. If you got the Johnson & Johnson vaccine, I wouldn't, the problems happen usually within 1 to 2 weeks. I mean, if you're past 1 to 2 weeks, you're probably well out of the risk period. Males, I think this is almost as low as the background rate of this kind of problem in the general population. I'd also point out, females of reproductive age who take oral contraceptives have a higher risk of blood clots, about 50-fold higher than this risk. And lots of women are on oral contraceptives and take those quite readily. Now, it's a different kind of clot. This is a more unusual clot, and maybe even more serious because it can affect the arteries and it can affect the vein in the brain. But just point out, like, oral contraceptives are used very, very commonly, and they carry some risk, low, higher than this risk, and it's something that we readily accept. So that's sort of my advice on those vaccines and the Johnson & Johnson vaccine.
Perfect. Thanks, Dr. Carson. Dr. Newman, I'm wondering if you can talk about whether or not mRNA affects the immune system in the long run, or just the safety of the mRNA vaccines in general.
Sure. I may have Paul go into a little more detail with that. I'll tell you what I loosely tell my patients. It's an analogy I think they probably maybe the older parents won't understand this, but I explain it that these mRNA vaccines are like Snapchat. They send a message to the body to produce spike protein, and then they leave, then they go away. So there is no long-term effects, and it's not thought that they affect long-term immune function. Paul, you could probably do a little more scientific than that.
Yeah,
that's what I tell teenagers.
I like the Snapchat analogy. Although I hardly know what Snapchat is personally, but one of the technical difficulties of the mRNA vaccines when they were trying to develop them is that our bodies are so good at shredding foreign RNA, they couldn't get it to last. It was kind of destroyed so quickly by our bodies that that it was a real technical difficulty for looking at this as a possible vaccine candidate. They eventually kind of found a way to kind of put it in these lipid bubbles, these sort of little fatty bubbles, which allows it to survive for a day or two. It makes it about a couple of days, and then it's broken down. And kind of along with, so you get a big burst of making, using our own cells to make spike protein for a couple of days. And then we make an immune response to that that's really quite remarkable. And then that process is kind of done and gone. The other question that sometimes comes up is like, are we tinkering with our DNA? Are we tinkering with our genes? And actually, this is RNA, just like the virus, puts into you. And we actually don't have the mechanism in our own cells of making RNA into DNA. It can't become part of our DNA. It does not get into our DNA or our genes or our chromosomes. In fact, like I said, the technical issue was getting it to last long enough to do the job of making, in this case, spike proteins.
Perfect. Thank you. To add on to that, Dr. Carson, I'm wondering if you can just also talk about maybe like people who wonder about the long-term side effects of the vaccine.
Sure. So, as I mentioned a little bit ago, well, first of all, worrying about the long-term side effects, it's reasonable. It's reasonable to kind of think about, well, what is this going to do to me a year from now, or 2 years from now, or 3 years from now? We don't see that with almost every other vaccine. Like I said, almost all serious adverse effects happen within the first 6 weeks, because that's when the immune system is kind of ramping up the highest. And as it fades away, we typically don't see problems as that effect fades away. But you have to balance that against the very obvious, very real long-term effects of the virus, which we're getting a study every day now showing how serious this is. To me, it's not even remotely close. I mean, this is so out of balance here. The sort of phantom theoretical, could the vaccine be doing something to me over the long term versus the obvious thing that COVID itself is doing. And so far we're finding nothing. And we have people now out 6 months in the Pfizer study with full FDA licensure, and we have ongoing monitoring for these problems. But as I've said, with all other vaccines, we don't see that as a problem usually going out into the long term.
I can add I think from my perspective, the answer is we don't know in kids yet. Just this Pfizer vaccine that, we just got this week, that actually started like in January, late December, January. So we're only about 5 or 6 months of that data. But to Paul's point, exactly. I mean, you normally see things in an immediate way, but they will follow the participants for 2 years to monitor that. But I think that's unanswerable for kids right now.
And I'm surprised it wasn't asked about the fertility or pregnancy or anything like that. But I don't know, Kylie, if you think, are there any other open questions out there that we should be addressing?
No, I don't see any other questions. If you have any other questions, please type them in the chat box.
Or in the question and answer box.
Or in the question and answer box, yep. Dr. Newman, since we have a few minutes here, would you mind touching on just the safety of the vaccines in pregnancy and in breastfeeding women?
Sure, I'd be happy to. I thought we were going to be pressed for time. I get asked this a lot by my patient population. And really the answer, at least for in pregnancy, is there was, I think, just a new study out today about this as well, but there currently is no evidence that this vaccine causes problems with pregnancy or with the placenta development or health. And this is a limited area, but growing, of data. There are clinical trials that have shown no safety concerns in animal studies, and we have human trials underway and more that are planned. But recent reports have shown that pregnant women who receive the mRNA vaccine during pregnancy, particularly if they get it in the 3rd trimester, that they are likely passing protective antibodies to their fetus, which is very promising and could help protect the baby after birth. And then just kind of to oppose that with, we know that pregnant women are at a much higher risk of effects from the disease of COVID-19 versus non-pregnant women. So unfortunately, you can see the rates listed here, substantially higher rates for moms, preeclampsia, needed to be admitted to the ICU, and unfortunately even death. In one study, it was 22 times higher. And then for the babies, we're seeing much higher risks of being born small, being born early, severe outcomes, and you have a 6 times higher rate of needing to enter the NICU for your care. One that comes up a bunch too is, I've heard the COVID vaccine can cause female infertility. Is this true? No, this is false. And there's sort of a main way to think of this. Well, first of all, there's just no evidence that the COVID-19 would result in infertility. And interestingly, in all 3 of the manufacturers' clinical trials, there were women in the vaccine arms that became pregnant. And they have been followed by that V-Safe program. We have over 87,000 vaccinated people, and there's 5,000 in the registries trial. And of that, to date, we've had no increased problems. And then just the bigger point that if this theory were true, you would almost expect to see higher rates of infertility occurring from natural infections as well. And that just is not the case when you look at the hundreds of millions of infection worldwide and within the US. As for breastfeeding and the vaccine, this really just is not formally studied, but it is, biologically implausible that any of the actual vaccine components are entering the breast milk. Promisingly, it is thought that the antibodies may be passively transferred to the baby, which then could confer protection to the baby. And, by and large, vaccine is considered safe and recommended to both groups of pregnant and breastfeeding women by all major medical associations.
I'm going to answer, Ryan is asking a question about the J&J vaccine because of the one dose, which is very attractive to a number of people, kind of the one and done. And I'm guessing, I'm not sure, I'll guess that Ryan is a male. Wondering if that's, acceptable, or is the 2 shots of the mRNA vaccines better? The Johnson & Johnson vaccine in clinical trials, including in South Africa, where it had to contend with the South Africa variant, which is a little bit more resistant to the current vaccines, performed. I think the overall, if I'm remembering right, the overall efficacy rate was around 72%. But it was very good in the 90+% against hospitalization and death, and that's kind of held up in other places as well. So for the most serious adverse events, which is really what we're trying to prevent, the Johnson & Johnson has performed essentially as well as the mRNA vaccines. I would have no hesitation to get that if that kind of one and done is attractive to you, or if family members or friends or whatever, where it might be an issue getting back in for a second dose. I think J&J vaccine is still a very good option there.
Yeah, I think so too. Just to add to that, Dr. Carson, for Ryan, who's asking that question, might be a good idea to talk to your healthcare provider about, your current health status, and maybe see if they have an option in the office that day. I think they're all good options, and vaccination is really what's most important at this point in time. The product is not necessarily the most important part. So here's a question for you, Dr. Newman. Sandy's wondering why the adolescent study group was a bit smaller. I'm wondering if you would feel comfortable addressing that question.
I can do my best. I don't really know. I don't know if it was, I know that basically the way Pfizer conducted this trial is they made it just an extension of their trials that were already going on with adults. That was especially true of the 16 and up. So they just continued that process to include more adolescents. That has been kind of brought up by many smart people in the pediatric community, and it certainly would have been preferred to have a higher number. But I still think, from what we have and the overwhelming risk versus benefit of some of the things we're seeing emerge in children with actual COVID disease versus the risk, of anything with the vaccine, I still think it's very much worth doing, and I'm recommending it to my patients. And we'll continue to follow. So hopefully, and we should get more data from Mrna and Johnson & Johnson. So hopefully that will yield to the conversation. This is a first for us. We've never had a pediatric vaccine be used in emergency use form. We've always had them full licensure. So we're all just watching.
Yeah, thanks, Dr. Newman. Let's see here. Dr. Carson, a question from Julie, one of our local public health unit nurses. She has a question asking about antibody levels after vaccines. When donating blood, someone was told they had no protection. Testing is not always accurate to show protection or not. Any other comments to like the blood test showing antibody protection after vaccination? Oh, I think you're on mute, Dr. Carson.
Sorry, I just
That's
saw it. That's a good question. So somebody gets, by whatever means, they get an antibody test done after vaccination. So first, I want to make sure that it was long enough after vaccination to mount an antibody response. So you'd want to have, I'd say, a minimum of 2 weeks after the last dose to have a reasonable amount of time to mount an antibody response. But if somebody had an antibody test that long afterwards that showed nothing, I would be concerned that they aren't protected. Now, we know that from the vaccine trials and from some of the real world data that's coming in, that anywhere from 5 to up to 15% of people, didn't respond or didn't get protected from the vaccine. And that may be more often, that certainly is more common in people who have immunosuppression, so people who are on medications that may suppress their immune system. But I think we're gonna have to wait to hear about some guidance on what you would do with someone like that, because in other situations, we may give an additional booster. We have no data on whether to do that or not. But if I had that kind of a person telling me they had no antibodies, 2 to 4 weeks at least after the last dose, I'd try and still be careful until there was very little transmission in the community. I'd probably still be doing, the personal protective measures to try and decrease my level of risk.
This is just a great example of why we need the herd, of why we need others to be vaccinated to help protect people in this situation or others.
Yeah, I'm going to answer, it looks like, Sorensen's question on 2 trends. First, giving just 1 dose of each of both of the Pfizer and Mrna. Second, just giving 1 dose of either. Maybe I'm not
But how I interpret that question, Dr. Carson, is what are your thoughts on giving a dose of Pfizer then a dose of Mrna? So mixing brands, and then what's your thoughts on just getting 1 dose of either? That's how I read that question.
Okay. So on the mixing, the formal advice of the CDC is not to do that. There's actually a study going on people where that inadvertently happened and looking at their immune response. I mean, the truth of the matter is that it's probably okay, and you'll probably mount, just as good an immune response, but we don't know. But a formal study is being done to look at that, at the mixed doses. Formal recommendation, don't do that. Stick with the vaccine that you started with, because that's what's been studied in the clinical trials, and that's what we know for safety and efficacy. The second question about just 1 dose, there is some protection afforded from just 1 dose. I wouldn't do that as a strategy of just, that's all I'm going to do. The UK took that on as a strategy to try and get more people vaccinated, get at least one dose into as many arms as possible. And then, catching up with the second dose later. That's a reasonable debate. There's a very good debate to be had there. And that debate occurs in public health and infectious disease and immunology circles on, whether that's a good idea or not. And I think you can make a good case for that. That's not the way we've done it in the United States. There's no reason to do that in the United States now. We're trying to get people to come in and get the vaccine. We have no vaccine supply issue now, certainly not in North Dakota anyway. I think we kind of hit them all here.
Yep, I think so too. Okay, well, thank you everybody for joining us. We had a great discussion, lots of great questions. Like I mentioned earlier, this recording will be made available in the near future on both the North Dakota Department of Health website and the North Dakota State University CIRI website as well. If you have specific questions for us at CIRI, you can email us at ndsu.cire@ndsu.edu. Thanks everyone for joining and have a great night.
Thank you.
Thank you.
Bye, everybody.